Hello, and welcome to Creating a New Gold Standard, Healthcare Supply Chain Best Practices in Other Industries, presented by Cardinal Health. I'm Eileen McDonald, the Executive Editor for Fierce Healthcare, and I'll be moderating today's webinar. It's my pleasure today to introduce our speaker, Mark Graban, author of Lean Hospitals. You can read his full bio on the left side of your window. Before we begin the presentation, I want to go over a few technical notes. If you'd like to download the slide deck, please click the Files button, which is located at the lower left of your screen. This webinar is being recorded and will be available on demand within 24 hours after the event. Following the presentation, we will have a Q&A session. You're welcome to submit your questions throughout the presentation by clicking the Q&A button in the lower left corner of the screen. Okay, now it's time to begin. Mark, please go ahead.
Thanks, Eileen. Thank you, everybody, for being here today. Well, let's just start off and level set. I'm sure some of you are supply chain professionals, and some of you, this might be a new topic. A supply chain is really just the end-to-end flow of not just materials, but also the information in that supply chain. In Lean, we often think of this as the value stream. So this is not just the flow of materials within our organization, but it's everything that happens all the way back to the very early stages, back through a distributor getting items from a manufacturer, that manufacturer getting items from their suppliers. And this lean notion of the value stream is important because our goal is not to sub-optimize any one part of the system, but to try to maximize the flow and the performance of the entire supply chain. I think there's growing understanding within healthcare that, unfortunately, there's too much waste in the healthcare supply chain. This is not that it's anybody's fault, but it's a matter of systems and processes which give us an opportunity to improve. In the Lean mindset, we look at reducing waste as being a better alternative to maybe the traditional approach to cutting costs. Cutting can lead to some unintended or unfortunate side effects. Reducing waste, eliminating activity that isn't useful, doesn't add value to the customer, doesn't have any side effects. There's a lot of waste in the supply chain. Within the high-value medical device supply chain alone, studies show $5 billion of annual waste. And again, waste is a cost, an expenditure that we aim to eliminate through lean practices. And in a different survey, supply chain decision makers, as you see in the chart here, were surveyed, and about 1/3 of them said that their hospital health system supply chain was quote-unquote very effective. 2/3 of them said that better supply chains would reduce costs, increase revenue, improve outcomes for patients. I think those are the right set of goals. There's sort of this choice of are you very effective or could you be better? And I think from the lean perspective, even if we're already very effective, there's an opportunity always to get better. But we're going to take our first audience poll here. We want to get your input from the attendees. If you had to choose just one of those answers, what would you say best describes your supply chain? That it's more that it's very effective, or is it really a situation where it could be significantly better? So please go ahead and vote and participate. We'll summarize those results in about 15 seconds or so. Votes are coming in. Maybe I biased the poll by talking about how we can always get better, if not significantly better. 8.3% of our, about 10% as it closed out. 10.8% of our respondents said their supply chain is already very effective, and about 90% of you said it could be significantly better. So I guess that's why we're here today. Hopefully I've got some ideas to help you create a significantly better supply chain. So when we talk about great performance, obviously the Summer Olympic Games just ended. We're talking about gold medals, gold standards. Gartner's is a research firm that does, I believe it's an annual survey and a study. They announce a top 25 list for healthcare supply chain performance. They do this for other industries. And within healthcare, their top performers, some of the criteria included demonstrating leadership in improving patient outcomes and lowering costs. This is core lean thinking, that we improve quality and cost at the same time, and that healthcare organizations are aligning these supply chains to patient care, company strategy, and future revenue models as we're in this era of payment reform, at least in the United States. There are different pressures around the world that lead us to look at supply chain as a significant opportunity for improvement, a driver of performance. Gartner, in their top 3 of this list from last November's survey, we see familiar names from the health provider side, Mayo Clinic and Intermountain Healthcare, and our good friends at Cardinal Health. They're number 2 on that list for the important part that they play in helping organizations improve supply chain performance. So when we think about the Olympics, though, there's different types of events. It's one thing that makes the Olympics, I think, fascinating. There are events that award gold based on judges' opinions, and there may be criteria, and maybe subjective evaluation and scoring and points awarded. And then there's some events where timing and measurement, quantitative measures, make it pretty clear-cut. Maybe if there's a photo finish, there's a different input there, but who is the fastest is something that can be measured. Who lifts the most can be measured. So how do we evaluate supply chains if we were to look for quantitative measures and scores? There are general measures used in supply chains across different industries in the broader business sector. Inventory turns, days of inventory on hand, fill rates, which is a measure not just trying to drive inventory down, but driving availability up. What percentage of time does the user of an item have what they need? That's a very important issue in healthcare supply chains, as we'll talk about today. The dollars of how much inventory is wasted because it's expired or damaged or not used for some reason, and expedited shipping costs that come from the kind of, oh, whoops reaction when we've run out of something or we're about to run out of something. I've seen a lot of hospital health systems have a significant percentage of their orders placed with overnight shipping or expedited shipping timelines, which increase costs. So there's an opportunity to reduce that. I think within healthcare, though, there are some particular measures that are unique to healthcare, the caring side of this profession. The percentage of time nurses spend at the bedside is a very important measure that impacts patient outcomes, quality, patient safety, and patient satisfaction. So using supply chain as a strategic driver, providing better service to nurses and other healthcare professionals can lead to some of these other measurable goals that impact the patient and have a direct impact to the health system's bottom line. Now, if we look at the auto industry, for example, if we think about lean methods, we probably first think of the auto industry, and look at just one of these supply chain measures, days inventory on hand, we see there's actually quite a bit of variation within that industry, about a 3-to-1 spread from the best performers to the worst. Toyota, maybe no surprise to people watching, ranks pretty well in this list in terms of, you might call this one measure of a lean supply chain. Ford actually has slightly better performance. But if you look at profitability, Toyota is 3 times more profitable on a per vehicle basis, which maybe illustrates a point that supply chain performance is an important factor, but it's not the only predictor of profitability as a key measure in the auto industry. Now, I think one key point, and I started my career in the auto industry, is that Ford and GM and others have spent a lot of time in the last 30 years learning from operational performance leaders in the industry, Toyota and Honda and others. And I think there are opportunities in healthcare to learn from the better performers in our space and to learn from the top performers in other sectors, even though hospitals and factories, hospitals and retailers, hospitals and hotels are different in some very fundamental ways. There are lessons that we can learn and bring in from other types of organizations. So we're going to go through fairly rapid fire here, about 20 different lessons that I think healthcare organizations can learn from industry, different industries. The first category falls into what I call basic lean thinking and lean culture. So lesson one is really about benchmarking, where I think there's a balance to be struck between looking at data, who's performing better than us, who has different practices that lead to better performance. Because usually that organization that performs better isn't trying harder than we are. They've got some different ways of doing their work. So, benchmarking matters, but at the same time, we don't want to be satisfied with being, let's say, in the top quartile of an industry that underperforms other industries in terms of supply chain performance. So there's this concept first of Kaizen, the Japanese word that's probably more familiar to people, continuously improving our supply chain in different ways. But there are times when we need really more step function improvement, radical improvement. If you are playing bingo with Japanese buzzwords, kaikaku is a word that you might not have on your bingo card. That is a word that translates to mean radical improvement. And there's a time and a place for that, redesigning the supply chain and then continuing to improve it. So if we already have a very effective supply chain, we still have that opportunity for Kaizen and continuous improvement. So we're going to open up our second poll, get more of you participating here again. How does your healthcare organization supply chain compare to peers? There's longer answers here, 5 answers ranging from, well, I know it's better than most and I have the data. I suspect or think it's better. Middle ground, well, it's typical. I suspect it's maybe worse than most, or I know that it's worse than most. And again, we have data to back that up. So I'm curious, we're going to have a bell curve. There's a bit of a bell curve forming here. So we still have votes coming in. That is a bell curve. 54% of you, percentage-wise, said you're pretty typical. There's about 28% of you who think it's better than most, and about 16% who think it's worse than most. So thank you for voting on that poll. Very interesting to see. So when we talk about numbers and measures, and of course, that's very important. But one thing I've had to learn as an engineer coming into healthcare is to have a better appreciation for the human side of the work we do, that there is meaning and value to having effective supply chains that go beyond just cold, hard, measurable numbers. So I'll tell a story from a hospital I worked with. This is about 7 or 8 years ago. And you see this picture here. This is a picture looking into an MRI control room at a children's hospital. And one morning I was there. It was very early in an initial lean project. They didn't have what we would call a lean culture or a lean management system. And they had some problems. One day I was in there and the MRI technician said, hey, I want to tell you what happened yesterday. And she said, we had a patient who was sedated and on their back in the MRI. And because they monitored the patients very closely, they noticed, unfortunately, the kid got sick. He was probably having a bad reaction to the anesthesia. So she detected that. She was doing her job. She went in there, and her first thought was, well, I need to grab suction tubing to make sure that that kid's airway was going to be clear. And as she told me, she went up to the wall in these clips and where the suction tubes were supposed to be hanging, and there were no suction tubes. You look at this and say the supply chain had failed her and that patient. So this is where I think understandable panic kicks in. She started digging around in this plastic bin, a jumble of different supplies, couldn't find suction tubing. She left the room, went to the locked automated cabinet in the control room, opened it up, logged in, couldn't find suction tubing. So she had to go down the hall, interrupt another procedure. She found suction tubing, came back. Thankfully, the kid was okay. But she was shaken by this. I mean, there was a happy ending to the story, but she realized that this was a near miss. She was tearing up a little bit talking about what happened. So I'm by nature a problem solver, and I started asking, well, what happened? Why do we think we didn't have this here? And we had an opportunity to go through a more formal analysis of trying to look for a root cause, not who messed up. In Lean, we talk about asking the 5 whys. Really, 5 should be crossed out. We say maybe it's the many whys. It's not always magically 5, but we're asking why, not just who, but asking why a number of times, making sure we're getting some sort of root cause. So we ask, you could start and say, well, why was there a near miss? Suction tubes were missing. Why were suction tubes missing? They hadn't been restocked. That was a fact. Why weren't they restocked? And we started looking into what's the process? Not whose fault was it, but what is the process? Who was supposed to be doing it? And everyone agreed, well, that was everybody's job. Which, as the old poem and story goes, well, that meant it was nobody's job. It didn't happen. There wasn't clear responsibility. It wasn't being managed. Why was it everybody's job? So, well, it's just, there wasn't really a well-designed material system, that last leg of the supply chain. Why wasn't it designed properly? Now we're getting kind of esoteric here. Well, what I found in healthcare, and I don't mean to blame healthcare leaders, but operational details are often just not the focus of clinical staff and managers. That's not what they're educated on. It's not what they're trained on. They have clinical excellence, but we still have operational problems, and maybe asking why, that becomes a pretty big picture question. How do we solve that? But the question in the short term was, how do we fix the processes and the reaction within the organization so when a problem like that occurs, it's resolved quickly and we can get to the root cause and prevent future occurrences. So lesson 3 from lean manufacturing is this idea of pulling the Andon cord. Here's a picture of me grinning. I'm at a Toyota visitor center in San Antonio. I'm pulling a demonstration Andon cord. It's kind of fun, I guess, right? You pull the cord and chimes start blaring. That's what you have in an auto factory. Now, in healthcare, we don't necessarily need to hang a cord in the room, but we need a process where people can speak up and point out a problem and get help in different ways. So we could think of that stock out for suction tubing or any medication or anything that's missing is a defect in the supply chain process. So the traditional approach is we react, we firefight, we have heroic measures, and then we go back to work. And that's exactly what had happened in this scenario. That wasn't the MRI tech's fault. That wasn't anybody's fault. That was just the organizational culture. Where the lean way would be, to at least proverbially, I'm not going to say that word in the future. I'm pulling the Andon cord about that word being hard to say. We would speak up. We would flag a problem. There would be some initial reaction. Get the suction tubing. Save the patient. But then we would be speaking up and getting help from a manager or a leader to help improve the process. That was not part of the culture. It was really just that scramble and firefight culture. And that helped illustrate why lean methods from other industries, including this management process, this help chain that comes from flagging a problem, is something really important for healthcare. So as we're learning from others, whether it's other health systems, other industries, I think another important lean lesson is, sure, we can study others, but we want to be careful about not copying too literally. So again, for example, I think an Andon cord doesn't mean hanging a cord in every patient room or above every operating room table. In some settings, having a cord like that might be unsafe for a patient. So we need to copy the process, copy the approach, maybe copy the mindset. When we look at best practices, understand why that's a good practice. What problem was that other organization solving? And when we realize, and I see this cycle where sometimes people go and benchmark, and they find other practices, and then they say, well, but yeah, we're different. Well, yeah, you are different, and I think there's that choice then. Do we adopt the method, or do we have to adapt it in some way, instead of throwing up our hands and saying, well, yeah, we're different? Instead of copy and paste, maybe it's an example of copy and paste special, because our organization is different and special. Paste and match formatting of our industry. We can learn from others, and even going back in history, Toyota learned some of their supply chain practices by visiting American grocery stores in the 1950s, in particular Piggly Wiggly, which is fun to say and easier to say than proverbially. I'm going to stop saying that. But there's a great history there of people learning from different industries, and healthcare is starting to embrace that here in recent years. So our next section of lessons, we're going to talk about some more specific lean materials methods that are used in manufacturing and retail and other settings. So I think one really important lesson, and this is something that tripped up manufacturers 25 years ago and sometimes even more recently. One of the early books written about lean manufacturing, even before it was called lean manufacturing, Japanese manufacturing practices was the term that was in vogue for a while. There was a book titled Zero Inventories about this approach to what's called just-in-time supply chains. And the risk of people misinterpreting that book or not really understanding it is that they focused only on reducing inventory levels, only on reducing cost, which sometimes comes back to bite you and causes other huge problems. So I can remember even, it was about 15 years ago, a manufacturer that was making big, heavy industrial cranes, and they were in the midst of what they would call a lean journey. Unfortunately, they had cut inventory so dramatically, they had gotten past their ability to perform and deliver to their customers. So the bigger problem that they had created was not making customer deliveries on time. And so we had a Japanese lean consultant there who I was learning from and they were learning from. He reminded them, he said, well, job one is delivering to your customers on time. Job two, priority two, is low inventory. And I think that's something really important to keep in mind in healthcare, that sure, we don't want inventory to be a lot higher than it needs to be. Let's not be wasteful, but let's not create other types of waste in terms of outcomes and patient satisfaction, patient flow, because we're being cheap instead of being effective. Again, there's that difference between reducing waste and just cutting costs. We don't want to cut too much. We need to improve systems that allow us to reduce inventory and do that in the right sequence, not just cut, cut, cut. So part of my advice to organizations is they're adopting and adapting lean supply chain practices. If anything, err at first on having a little bit too much inventory. Because if you have a little bit too little inventory, people will lose faith in this new lean approach. So if you have a little bit too much at first, you can mitigate that risk by having good flow, flow racks, stock rotation to help make sure you're always using the oldest inventory first. In some cases, you can track individual items electronically if they're high-value items. And you can also use tracking solutions to help not just measure inventory levels, but measure fill rates, availability, stockouts, and make sure, again, that we're keeping things in balance. First, meet customer needs. Secondly, do so with the lowest possible inventory level. So along those lines, when we have this mission and purpose in healthcare, this is a lesson even for manufacturing. Let people focus on doing real value-added work. When I've taken people from healthcare to the Toyota factory in San Antonio, they're always really impressed that there are systems and processes and a materials team there being of service to the people doing assembly work, the team members building cars or trucks. In healthcare, nurses, different studies have shown, and I've seen this in my own observation, nurses often spend about 30% of their time in a given shift searching for missing supplies, missing equipment, missing medication, missing information, which takes them away from the bedside. And so I've seen supply chain leaders in healthcare come from manufacturing and say, we need to be of service to those nurses and other healthcare professionals. We need to make sure they have what they need to do their work so they can focus at the patient, so they can be at the bedside, which improves patient care. As an example I've seen in a primary care setting, this is what we call a spaghetti diagram of a podiatrist running around for about 10 minutes, gathering up supplies he needed to do a small toenail procedure for a patient. So this is 10 minutes of wasted time for the doctor, 10 minutes of delay for the patient. This really hurts productivity and financial performance of the clinic. If we can solve these problems, everybody wins. The patient doesn't wait as long. The doctor's more productive. We can see more patients per day. That's good for the financial results of the organization. So we need to stop wasting the time of medical professionals. The next lesson is the idea of point-of-use inventory. Here's a picture from a car plant where you see items are right there at the side of the line. People have what they need to do their work. Everything's within an arm's reach, and there's essentially an army of materials management and supply chain professionals working behind the scenes. It looks like everything is this kind of just well-oiled machine, a clockwork of parts being delivered and resupplied and making sure we don't run out. That same thing was done basically in this clinic to help the podiatrist. So you see the cart pictured in the lower right here. The team there realized the doctor shouldn't be running around like that. You know, he had accepted that as normal, but it didn't have to be that way. The team decided they were going to have a cart of all the items that the podiatrist needed. They could park it basically at the point of use just outside the 2 exam rooms that he tended to use. So at first he was a little skeptical. You know, he didn't realize there was a problem. Then once he saw the spaghetti chart and realized that there was a better way, he was thrilled because this made his day a lot more productive, a lot less frustrating. So this general idea, and we see this in different settings in healthcare, give people what they need at the point of use. Don't make them run down to the end of the hall, to different supply closets or utility rooms. You need to do that for them. So we were talking earlier about the Olympics. Golf was an Olympic sport this year for men and women. So the term par enters into golf terminology. Well, when I first got into healthcare, I heard people talking about something called a par level system, and I was sort of confused. I know others who've come in from other industries have had the same reaction where I had to ask, what's a par level system? And people asked me, I thought you knew something about supply chain and materials management. And I said, well, I thought I did, but I don't know about this. You know, a par level system is, as I learned, you know, it's a form of a pull system. If we used 7 of something, we replenish 7. If we used 13, we replenish 13. So that's good. It's a pull system. That's a lean concept. The con or the downside is that there's lots and lots of counting involved. Lots of extra effort. You could argue this is wasted motion. Materials management professionals can be of better service to the frontline care providers if they're not just counting parts all day long. We can eliminate the waste in this process. As one supply chain director at a hospital said to me as they improved their approach, instead of counting widgets all day, we're looking at the quality of the system. Are we meeting the needs of our patients and our healthcare professionals? So lesson 9, you know, if there's too much waste involved in par levels, we can accomplish essentially the same thing by borrowing something from manufacturing called a Kanban system. And we often use what we call a 2-bin approach. It's the same math. It's essentially the same inventory levels as a par level system, but we end up with a clear visual signal. We don't have to count. We see an empty bin. That means essentially half of our inventory is gone. There's this unambiguous signal that says, all right, it's time to get more. There's a fixed quantity. There's less of this confusion about is it 7, is it 9, is it 13, because we may set up the Kanban system to deliver box quantities, which further saves time for the supply chain professionals because they're not breaking down boxes, opening boxes, repackaging things. They can grab a box from the central supply room, put it on a cart, bring it to the unit, save time for everybody involved. So I've seen a lot of health systems in a lot of different settings really find that a Kanban system can be quite helpful, freeing up hours of time every day for those supply chain professionals so they can kind of step back and work on higher level challenges that better serve the organization and the patients and the staff. So if we have a pull system, we have a Kanban approach. Now we have our other Japanese word, Kaizen. We can Kaizen the Kanban, which maybe sounds a little silly, but we have a pull signal. We can improve the way that pull signal is sent. So years ago back in manufacturing, and I've seen this in some health systems, the Kanban signal was the empty bin. That empty bin would have a label about what needed to be replenished and what quantity to what location. And that empty bin might be physically transported on a cart or on a truck back to a warehouse, back to a supplier. And over time, people realize, well, yeah, we don't really need to go through that. It's wasted motion or wasted transportation. It delays the replenishment because what we really are sending is information that says you need to bring us more. So the middle ground, I wouldn't call it the modern approach. 15 years ago, factories started using fax machines to send electronic signals. Then they started using electronic data interfaces, EDI, and today modern Kanban systems in different industries are really all about sending electronic signals through software or the internet or different portals that people use. It's really a matter of that electronic information, which can be sent via barcode scanning or other ways of automating the counting. And so I think one of the exciting trends that we've seen, and this has really been embraced in retailing, high volume retailers that have lots of items that they're restocking very frequently, have started using RFID technologies, radio frequency identification. When I was at MIT about 20 years ago, this was being touted as, man, this is the wave of the future. But RFID chips at the time were still too big and too expensive. Well, like with a lot of technologies, the cost has come down dramatically. They're much smaller than they used to be. And so RFID technologies can be used to automate either the counting to know how many items are there. A lot of high-value medical devices and implants, we really need to tightly manage that inventory. So we might want to use something like a par level and really micromanage the amount of inventory we have. And that's where things like RFID tags can be very helpful. We use 2 today, send a signal to the distributor, bring me 2 more. And there's different technologies like smart cabinets where somebody pulls an item off of a shelf and it automatically detects we've used something. Unless the procedure gets canceled and it gets put back on the shelf, and again there's a signal that says, there's one more back on the shelf. Or you have RFID wands, which can be waved over different bins on different shelves to, again, make that counting process both faster and more accurate than someone physically counting with their eyes and their hands. So when we look at different technologies like this, I think there is a lean mindset about technology, and from what I've learned about what Cardinal Health is encouraging and teaching people, we want to use the right tools and the right technology for the right application. Toyota and lean organizations sometimes get, I think, unfairly labeled as being against technology, when really what they are is not counting on technology to be a silver bullet. I've seen some hospitals kind of go overboard with automated cabinets that solve one problem that maybe don't solve some of the problems they thought they had. It creates other problems like nurses standing in line to log in to a cabinet. As you see in this diagram, low-cost supplies, gauze, bandages, basins, things like that. We don't need to use a lot of technology. We can do a simple 2-bin Kanban because the items are small, they're inexpensive. We want basically the quick and dirty method that's effective. And then as items get more expensive, we may use barcodes, smart wands, smart cabinets as we kind of go up that cost curve. So I think one of the key lessons there is the right technology for the right application. Now we can also use technology to help us understand how we size our inventory levels. So with a Kanban or even with a par level system, we set up inventory levels based on our forecasted or projected use of items. In some organizations, I've seen people really struggle because they don't have data. They're guessing. People are saying, well, I think we use 5 of those a day, and that might be accurate, it might not be accurate. So as we use electronic systems to communicate and possibly to help count, we gather data. That data can be incredibly helpful, not just what are we buying, but what are we actually consuming in different parts of the organization. Sometimes purchasing data is not granular enough to know how many we need in this unit versus that unit, or this OR versus that OR. So we're setting those levels based on our planned usage, which might include our knowledge about seasonality throughout the year, or we can order based on our actual known schedule. So when I worked at Dell Computer and their supply chain group about 15, 16 years ago, Dell was really well known at the time for what they called a pull-to-order system. They didn't use Kanban. They worked off of production schedules, actual production schedules from actual customer orders every 2 hours, and they put an order into their distributors who delivered parts every 2 hours. So really fast-churning supply chain based on actual need, not projected usage. So either way, if we're trying to adjust over time or really precisely order exactly what's needed, let's say based on an OR schedule for the next day, software can help us detect patterns, changes in usage, flag us if it seems like usage has gone up or usage has gone down, so we can adjust accordingly, adjust the sizing of the inventory for that pull execution of the supply chain. So lesson 14, there are times I think where people read about Lean and they say, well, if we have pull, if we have just in time in our supply chain, we don't need forecasts. And I think that's not really true. Even Toyota uses supply chains to plan what the suppliers need to produce and distribute. Dell, back in those days, when they had that build-to-order model, they still had forecasts that were required to help stage inventory so that they could execute based on real-time demand. So we can't rely too much on forecasting as they used to do in manufacturing, because one of our lessons is forecasts are always wrong. So that's why we need a smooth-flowing supply chain. So as demand changes, we can be more responsive, avoid stockouts, avoid problems that affect staff and patients. So our third section of lessons here is about some other lean supply chain concepts, not just materials management in the organization, but the broader supply chain. And one of those lessons is that supplier location matters. If we have a choice, there's simple math. If we choose suppliers that are located closer to us, and that could be manufacturers or distributors or different sources, having suppliers closer to you means lower inventory, and it means higher fill rates. So again, we have these dual goals. Higher fill rates probably should be first. That Japanese consultant would probably give me a look. First is higher fill rates. Second is lower inventory. And when we have suppliers or distributors that are located close by, we have lower supply chain transportation costs, which means we can order more frequently, which means we have a more adaptive supply chain. We have a lower likelihood of stockouts and problems when demand spikes. So I think one of the other lessons from other industries is to step back and actually design our supply chain. It might not be a matter of redesign. We might just say, hey, we have a supply chain that just sort of, it's there. It evolved. It happened. It's the way we've always done things, which we're trying to fight against with Lean. Let's challenge the way we've always done things. How should we do things? Who orders supplies? Who chooses the items and vendors? Where is inventory stored and staged? So the first thing we would do, instead of just going and benchmarking and copying someone else's supply chain, we might start by looking at our own current state. Do we have different departments ordering different items from the same vendor with a long lead time, which leads to higher inventory, poor supply chain performance, where a different department is ordering an item from a different vendor, which might have a slightly higher cost per unit, but there's a shorter lead time, which maybe helps optimize the overall supply chain cost, the total cost of supply chain. So if we see that we're not leveraging volume pricing, if we're holding too much inventory in each department instead of having a better supply chain network within the organization, we can brainstorm different ways we can improve based on what other organizations are doing, based on lean principles, based on our own creativity. So we might change the supply chain to say, well, these different departments need to agree on a consolidated item. We're all going to use the same item for the same purpose. Easier said than done, but you can get that agreement if you work with people. In the ORs, this needs to be driven by surgeons, but it's possible. That we're going to be ordering, let's say, from some central, what we might call a supermarket. There's the terminology that comes from Piggly Wiggly and Toyota. I said that was easy to say. Piggly Wiggly. And then the supermarket is the one ordering from a vendor. So we might be able to get away with a longer lead time because the supermarket is buffering against demand variation and delivery time variation, delivering to the different departments with a short lead time, which helps improve availability of parts and supplies. If we look at Tesco, a retailer that's primarily based in the UK, they've used lean practices to really redesign their supply chain. Step back and ask, for example, for cola, for soda. Before Lean, they had 5 different storage locations, different inventory points between the bottler and the consumer. With the Lean approach, they got that down to just 2. Before, they had 6 different order entry points, which led to confusion, different demand signals. They got that down to 1. That just 1 point in the supply chain was going to order more cola. So through these improvements and improving flow, throughput time to get restocked went down from 20 days to 5 days. They had a 75% reduction in inventory, but more importantly, showing the dual benefits, they increased their service level or their fill rate from 98.5%, which had been above average, to 99.5%. It's rare that anyone gets 100% performance in retail supply chains. In healthcare, there may be certain circumstances where 100% is the only acceptable number. So that's an adaptation from other industries. We may need to have slightly higher inventory. We may accept the risk of, an item might expire, or we might have slightly higher inventory, but that's better than the risk of running out of something. Those are part of the trade-offs. That's one way healthcare is different. It's not just the financial cost, it's also the human cost. Did I skip a poll? I think I did. So our next lesson is the idea that visibility helps everybody in the supply chain. So at MIT, they teach something from the field of system dynamics that's not quite as much fun as it might sound. It's called the beer game. And because it's MIT, there's no beer drinking involved, but maybe in an adult education class you could. But it illustrates something called the bullwhip effect, or what's sometimes called the beer game effect. This is a simulation of a supply chain, similar to Tesco and Cola. You have 4 different teams playing the role in the supply chain of the retailer, the wholesaler, the bottler, and the brewery. You send demand signals back upstream, and you decide how much you're going to produce and how much you're trying to order. And what we learn is that even in a very simple supply chain, when there's a shift in demand, that gets amplified as you go further upstream in the supply chain. It causes more and more chaos the further you get away from the end customer. Time delays in replenishment make this effect a lot worse. So in the typical beer game, the retailer sees that demand jumps from 4 to 8. The wholesaler and the bottler and the brewery don't have visibility to that real demand. The retailer is just ordering based on what they think they're going to need in the future. And so what happens is these demand signals get distorted, people overreact, inventory goes out of control, and at the same time, in different periods, you're not able to ship enough to the retailer. So one of the lessons from playing the beer game is that you need to give electronic visibility of real demand to all of the stages of the supply chain. And if you can improve flow time, reduce delays for getting supplies and materials through the supply chain, it lessens the impact of that bullwhip effect. So we've seen a lot of examples in retailing and auto industry to send real-time customer demand to different points of the supply chain. And again, we do that electronically. One of our last lessons here is the idea of partnering with suppliers, being collaborative, working together in a different way. So again, if we look in the auto industry, there are annual surveys done basically asking the suppliers, how good is it to do business with these different customers? Now, a lot of this is anonymous. Nobody wants to criticize a customer directly. If you look at these ratings, again, there's a range of which customers are easiest to do business with, who communicates the best, who communicates well about demand changes. Toyota and Honda rank very highly in that in that survey. BMW actually does really well. And what we tend to see that leads to happy suppliers, it's also about high-performing suppliers. That lean organizations tend to partner with suppliers. They value long-term relationships. They're looking for total value, not just the cheapest item, the lowest piece price. Lean customers do what they can to level their usage of items when possible. There's this Japanese word, this concept of haijunka, level loading our workloads. So in manufacturing, sometimes that's easier than in healthcare, because in healthcare we have to react to people's needs, their seasonality. But if there are ways we can try to level load surgeries within the week, if we can do more elective cases in the times of year when we have lower emergency cases. There are some things, some levers that healthcare organizations can pull to level their use of items at least a little bit. But even when there are changes, Lean customers communicate trends and usage forecasts in a more timely manner. They look for shared savings opportunities instead of just telling the supplier to give us a lower cost no matter what. And that trust and that long-term relationship over time leads to a more adaptive supply chain and greater responsiveness when problems arise. Those suppliers feel a stronger sense of commitment to the customer. We see when there's been supply chain disasters in the auto industry, there's an earthquake or a fire that affects a Toyota supplier plant, other suppliers tend to chip in and do what they can to help bail out that other supplier for the sake of helping Toyota. And I think a lot of that comes because there's generally less animosity than we've always typically seen or heard about from other companies in the auto industry. So to wrap up, our fourth group of lessons are about some of the broader lean improvement mindsets. So I think lesson 18, as executives or supply chain leaders or business leaders, we can't just demand better performance. We can't just tell people to try harder, to work harder, tell them to just reduce inventory levels. If that's the only lever we're trying to adjust, we might get a lot of dysfunction. So as leaders, it's our role to be collaborative, to help people improve processes and systems that allow us to actually have lower inventory levels, not putting the cart before the horse. Another lesson is this idea, if we are going to adopt new practices, new workflows, new technologies, to use what we might call a model line, to pilot new processes in one part of the organization. That reduces the risk. If we have a new process that's not quite perfect yet, we can use the PDSA model, plan, do, study, adjust. Do a pilot, see if the process works. If not, work out the kinks before we go spread that to the rest of the organization. And along those lines, the last lesson here, before we have time for Q&A. Lesson 20, look for not just win-win, as the late Stephen Covey would have talked about, win-win-win. Maybe there's more wins involved. But at least we want better performing supply chains, not just for lower costs. We need better performance for all stakeholders, for the patients and families, not putting people at risk, protecting their safety, helping them get discharged in a more timely way, reducing delays in care. For healthcare professionals, not wasting their time, not frustrating them, not taking them away from the patient and value-added work, and also for the performance of the organization, the long-term performance measured in typical balanced scorecard types of ways. That's what I would argue is the gold standard for healthcare. Lessons for materials management and supply chain from other industries that help us be the peak performers in our field for all of these important reasons. So with that, we're going to have some facilitated Q&A. I hope you've got questions. If you have questions after the webinar, you can send an email to this address. They'll be shared with me. We'll follow up. You can tweet at me. I haven't been looking at my phone, but I will after we're done here, and I'll respond to you there. So Eileen, we'll let you facilitate the Q&A.
Thank you so much, Mark. That was a fantastic presentation. I learned a lot. And to our listeners, there's still time to submit your questions using the Q&A button in the lower left corner of your screen. And we're going to try to get through as many of the questions that we've already received. And so we can begin. And Mark, first question. Regarding the point-of-use stocking, we are implementing some bedside stocking and are finding it a huge expenditure of my team's resources. Do you have any advice on how they can mitigate any of that?
Well, and I'm guessing the context of the question, my team means the materials management team. And, I think there are trade-offs here. So restocking supplies to a greater number of points of use, whether that's in rooms or carts that are in between every couple of rooms, is more time-consuming for materials management compared to restocking to a central utility room within a unit. Part of how we want to make that time available, I would suggest, is getting away from the par level system. So instead of spending time counting, we can spend more time delivering items to more points of use that are closer to the patient and the caregivers. The other thing I think at a big picture I would suggest to executives is to look at the total performance of the organization, not just the materials management group. We may choose to spend more on labor for materials management because that reduces overall cost for the organization, or because it improves overall performance. And I've seen times where executives sometimes will actually give a little bit of budget relief to the materials team so that they can be of better service to the people providing care, and that optimizes the overall system instead of just the materials function. So I hope that answered the question.
I hope so too. The next question is, have you seen organizations work with surgeons to reduce variation in what they use in the OR? Yeah,
I have, and I've seen that go really badly, not really get anywhere, and I've seen great things when to get that agreement and alignment, for that to actually work, it seems like it has to be driven by the surgeons and the surgeon leaders. If it's seen as something that administration is doing just to cut costs or to hassle us, people aren't going to participate. So when surgeon leaders realize that there can be benefits to the patient, there can be benefits to the organization, that it's increasingly hard to rationalize using one item that costs 10 times more than another. That's not ever an easy process to go through, but I've seen it be more effective, again, when it's driven by the surgeons as opposed to being driven by, or being seen as being driven just from a business function.
Thank you. Next question. My hospital is looking to adopt lean practices for inventory management in the near future. What's the best way to determine a model line area? What is the best place to start for a quick win? Sorry. Do you need me to repeat that question?
No, I think I got the sense of it. Where to start with a model line? That's a great question. I think there's different ways of prioritizing. Sometimes people look for where do we think is the biggest inventory, or biggest opportunity to either improve service, improve inventory performance. Do we have a lot of complaints coming from one area? Are there some areas where we think there's a lot of wasted inventory? Sometimes the biggest opportunity isn't the easiest proof of concept. So sometimes we might start in a smaller department. Let's say if the lab or the pharmacy has a director who's sort of volunteering and say, well, we want to go first. We're willing to pilot this. I think sometimes you can look and try to measure or estimate and choose a model line based on the impact, but I think you also need to look and see where there's pull from leaders, who's begging to go first. And I think sometimes by starting small, again, you mitigate that risk of not having a perfect process. Work out those kinks in an area that maybe introduces less risk to patient care, and then go spread those practices more broadly.
Thank you. Our next question, you mentioned 3 healthcare quality measures for hospitals to reference: percentage of nursing time, patient outcomes, patient satisfaction. How have the hospitals you've worked with tracked and measured these successfully in the past?
I think the one thing that's been interesting. I mean, hospitals, there's no lack of measurement, it seems, around outcomes and quality indicators and patient satisfaction. The other measure that I talked about, the percentage of time at the bedside, people generally have no idea. So that data has to be collected. That really needs to be done through direct observation, and I think that's best when it's peer-to-peer. When I've worked with nurses and we're trying to get a baseline of how people are spending their day, that might seem like kind of a threatening proposition. especially if it's an outside consultant or a process improvement facilitator. Who's this guy? I don't know them. I don't trust what's going on here. But when it's peer-to-peer and you teach them how to observe and how to collect that data, percentage of time at the bedside, percentage of time spent searching for stuff, percentage of time spent waiting for the computer system to log in. You can teach nurses how to collect that data. They're better observers because they know what's going on. Whereas an outsider, I would have to constantly be asking, hey, what's going on, at any granular level beyond, oh, they're in the room with the patient. I can tell that. But when it's peer-to-peer, it's less threatening. People collect better data, and you can have that baseline. I've seen there's hospitals out there. Virginia Mason Medical Center in Seattle has reported that their baseline was fairly typical, 30 to 33% time at the bedside. They're reporting something more like 90% time at the bedside in recent years, which I know at least part of the equation has been materials and supply chain. Some of that has been technology and computers that are more available, getting nurses out of the nurses' station and utility rooms and getting them at the bedside, at the point of care.
Thank you. And I hope I pronounced this next question correctly. What would an Andon cord in an OR or cath lab look like?
Yep, no, you got that. You got that well. So I think this is one of those ideas of an adaptation, of not going through the expense and hassle of hanging a physical cord for people to pull. In some Toyota plants, the Andon cord is actually now just a button that's easy for somebody to reach. What's really important is that you have a mechanism for signaling, here's a problem, I suspect there's a problem, I need someone, a team leader, to respond and help. So, there are some situations, again, like Virginia Mason Medical Center has what they call a patient safety alert system. That is directly inspired by the Andon approach, but they've realized, they need to help create a culture in the OR where people feel free to speak up, that there are no repercussions for speaking up, and if they're not getting the right response locally, they have a telephone hotline where it might not be as immediate as we would ideally want, but at least it signals that, hey, I'm not getting the right support, I need help from leaders who can maybe then help investigate why people aren't getting an immediate response to trying to call a timeout or trying to flag a problem in the system. So I think Andon approach, I wouldn't think of it as the cord, but think of it as an Andon process. How do you speak up? How do people respond? How do we solve problems?
Thank you, Mark. Next question. In the story you told about the MR suction tubing, who was held accountable for not restocking the tubes? We could do a whole webinar sometime about accountability. Because a lot of times, that's the reaction. There's a problem, and somebody says, well, we've got to hold people accountable. A lot of times I'll ask, well, what do you mean exactly? What do you mean by accountability? If it's a matter of blame and punishment, I think we need to be careful about that because it might be unfair to punish an individual for a system problem. If we punish individuals for system problems, people tend to hide and cover up problems, which gets in the way of improvements and better performance. So, no, I mean, in this case, the accountability, I mean, it really fell more on the department and the team to ask not just, who screwed up that day, but why didn't we have a better system? And the focus really more was more put on improving the system, having clear responsibility and follow-up, and making sure people had responsibility and time and that they had the opportunity to be accountable. And if something wasn't happening, I think the good lean habit is to ask why, not who. So I think that's, anyway, that's my short answer on accountability. Attempt at a short answer. Thanks, Mark. We've come to the end of the hour, and we had so many great questions, and we apologize we couldn't get to them all, but we will get back to everyone who submitted personally after the webinar. And I want to thank you all for attending today's Fierce Live webinar and submitting so many great questions. And a special thanks to Mark, our speaker, and to Cardinal Health for presenting today's webinar. This webinar has been recorded, and you'll be able to access the recording within 24 hours on the same page you used to register for this event. Thank you again for joining, and we look forward to seeing you at future events.